Division of Nephrology. It's my privilege to introduce Dr. Joseph Flynn as today's Grand Round speaker. Dr. Flynn comes with us. He's the Chief of Nephrology at Seattle Children's Hospital. And he is the chairman of the Committee on Screening and Management of Pediatric High Blood Pressure. And he is the lead author on the recent update on the guidelines for management and screening of high blood pressure in children. And without too much more introduction, I'm going to turn it over to Dr. Flynn, and hopefully we'll have a very enlightening Grand Rounds. Dr. Flynn.
Well, great. Thank you for inviting me. It's like I was telling folks at dinner last night, I've only ever been to Salt Lake City to change planes. So now I can say that I've seen a little bit more of it than you see from the air. It's great to be able to talk about the hypertension guideline, and I'm just going to launch right into it. So the obligatory disclosure is that I don't have any related to this talk. So the objective really is to understand what's new and different in the 2017 hypertension guideline and how it is going to affect the management of children in the office with elevated blood pressure. So why did we do this? Well, first of all, it's been sort of a long time since the last hypertension guideline in 2004. So that means that we wrote it in 2003. So it's a long time. But since then, there's actually been a lot of new interest in childhood hypertension. And there's been an increase in prevalence of hypertension in children. So now about 3.5% of children have high blood pressure. Another 10 to 11% have elevated blood pressure. And much of this is due to the obesity epidemic. But the important thing is that really what's not recognized by a lot of people is that hypertension is one of the more common childhood illnesses. It's relatively similar in prevalence to things like asthma and behavioral problems. And so it's really an important common problem. We know that high blood pressure in children increases the risk for adult hypertension and adult cardiovascular disease. And we know that there's evidence that in youth, you can see accelerated vascular aging, so it's something that starts early. The prior pediatric hypertension guidelines were all issued by the National High Blood Pressure Education Program of the NHLBI and were in 1977, 87, 1996, and 2004. 2013, due to the whole JNC8 debacle, the NHLBI decided to stop being the organization that sponsors guidelines and said, okay, you clinical societies, you do it. And also, since that time, there's been an increased emphasis on doing really thorough literature reviews and evidence-based guidelines. So we were asked to provide an updated guideline that would be evidence-based, that would give recommendations on what to do with the child in the office with high blood pressure. And really, it's outpatient focused. There's one small piece about acute severe hypertension, but otherwise the focus of the guideline is on outpatients. So just as a sort of top 10 sort of, what are the major changes from the fourth report? So we followed more of a evidence-based methodology. There are new definitions of blood pressure categories that are now in alignment with the adult guideline, which you probably read about, was just issued last month. There are new normative blood pressure tables and a simplified screening table. I'll talk about all these things in more detail as we go through. Increased emphasis on 24-hour ambulatory blood pressure monitoring, some different recommendations about echocardiograms, and then new lower treatment goals, really, for children with hypertension, and even a ambulatory blood pressure-based goal for children with chronic kidney disease. So we followed an evidence-based methodology as recommended by the Institute of Medicine for development of practice guidelines. And so we had an epidemiologist, and we followed the PICO-T format to formulate the main questions, and then literature search was conducted going back to January of 2004 through 2015. We did update it to, I think, June of 2016 at one point, but we had to stop somewhere. That resulted in 15,000 papers being identified in all the different databases. And then we went through the usual process of winnowing those down, and then used the papers to generate what are termed in the AAP lingo key action statements, which we'll be talking about, and then utilize this AAP grading matrix. I'll blow it up a little bit, that allows you to categorize the recommendation based on the strength of the evidence, benefit and harm. And so you'll see all the way from level A, which would be like a prospective clinical trial, which of course we don't really have very many of those in pediatric hypertension, down to level X, which is sometimes called level EO for expert opinion, or sometimes I call that inexpert opinion. And then depending upon whether benefit or harm predominates, tells you how strong the recommendation is. So first thing to deal with is how to define hypertension, right? Because in adults, you can pick a number and use that as the definition. And the reason why you can do that in adults is that we know that for every increment of blood pressure above ideal, which is actually 115/75, the rate of adverse cardiovascular outcomes and things like end-stage renal disease increases. So you can pick a number in adults and use that to, define your abnormal blood pressure level. But we don't have that in children because we're lucky as pediatricians. Very few of our children have heart attacks and strokes, and those that do have underlying problems that lead to those things. So we have to define blood pressure, abnormal blood pressure statistically. And the way that's done is looking at the distribution of blood pressures in the healthy pediatric population. And actually that was decided 40 years ago with the first pediatric blood pressure guideline that Dr. Blumenthal edited. And we looked at the evidence that's been generated since 2004. There are no new evidence, no new data to support a different approach, so we kept the same approach. Now, we did make some changes compared to the fourth report. Blood pressure greater than the 90th percentile is now termed elevated blood pressure, not prehypertension. No one liked the prehypertension label. What is that? And families couldn't understand it, really. And so elevated blood pressure is a little bit more concrete. And that's actually what was used in the adult guideline as well. We simplified the cut points for stage 1 and stage 2 hypertension. I'll show you that a little bit later. And then we chose cut points for adolescents that are exactly the same as in the adult guideline. And we did that actually for a good reason. And if you look very carefully at the very long tables in the new CPG, you will see that for 13-year-old boys and girls of average height, the 90th percentile is about 120/80. And so based on that, we felt that we could use the adult cut points for teenagers. And so here's our big table, table 3 of the definitions and categories. I'm not going to go through this in detail because I'm sure you've already looked at it. On the left-hand side are the categories for children aged 1 to 13, which are percentile-based up to the absolute value cut points. And then on the right-hand side are the cut points for children greater than or equal to 13. And I've gotten questions about, especially from people who work with the EMR, well, what do you do with the kid on their 13th birthday? Well, once they've turned 13, they're over 13, use the, the cut points for children that are over 13 or older. I thought that was obvious, but some people don't think that's obvious. I don't know. Then what to do about neonates and infants up to a year of age. So it's very hard to define hypertension in that age group because, especially in neonates, all sorts of things are happening to them in the first, few days and weeks of life that affect their blood pressure. But there are values that have been compiled for neonates of 26 to 44 weeks post menstrual age, and those can certainly be used to identify neonates with high blood pressure. For babies between a year of age or between 1 month and 12 years of age, 12 months, sorry, there are no new data, so the 1987 curves are still the only reference data for that age group. Okay, so what about the blood pressure tables? When the fourth report was published, there were normative blood pressure tables that were developed as part of that, and they were immediately criticized. Within weeks of publication, we got blowback on the tables because they included a big chunk of children who had overweight or obesity, and we know that excess weight drives up blood pressure, and so we were accused of saying that it was okay to have higher blood pressure, which of course it's not. And probably the inclusion of those children did bias the normal values upwards somewhat. So this time I wasn't about to get criticized for that. And so we got the AAP to commission new normative data tables that are only based on children with BMIs below the 85th percentile. So these are normal weight children. And so this is what it looks like. Very similar to the ones that were published in the fourth report. I'll blow this up a little bit for you. Here's the 1-year-old ones. Now we did do two things which hopefully will make them a little more user-friendly. The first thing we did is not only were height percentiles included, but actual heights. So in inches and centimeters, so that you don't actually have to plot the child on a growth curve anymore. You can look at their measured height and use that. And then the other thing that we did was we actually included the cut points for the different stages, 90th, 95th, and then stage 2, the 95th plus 12, which of course is different than what we did for the fourth report, which is the 99th plus 5, which was a little crazy. So hopefully this is a little bit easier to use. However, we recognize that even though we've made some efforts to make them a little more user-friendly, they're still big and cumbersome. The complexity of the normative blood pressure tables has been blamed for under-recognition of elevated blood pressure in the office. I don't necessarily think it's just a problem with the tables, but that's my own opinion. And so therefore, since the fourth report came out, there have been, I think, 3 different simplified tables that have been proposed in the literature, and one of which was proposed by my co-chair, David Kalber. And so this time what we did is we got the same statistician who developed the full tables to actually develop a simplified table for us, which is based on the 90th percentile blood pressure value for a child at the 5th percentile of height at each age group. So therefore, it has a negative predictive value of 99%. If you use it, and I'll blow this up a little bit, you can actually, what we're recommending to people is to, blow this up, post it in the vital signs station, and then the personnel who do the vital signs can look at this and tell you, oh, Dr. Grinsell, the child's blood pressure is higher than the one on the chart. And then Matt can go to the full table and figure out whether the child really has an elevated blood pressure or not. All right, so one of the other things that was important to address is when to start measuring blood pressure. It's really unclear what age you should start. All the prior guidelines have said 3 years of age, but there's not a lot of evidence base for that, excuse me. But we know that probably you should start early if the child has high blood pressure in terms of, preventive efforts as just good, basic, well child care. So we decided not to change the age at which to begin routine blood pressure measurement, but we changed the recommendation for frequency. So the fourth report said, measure the blood pressure every time you see the child. Well, that probably leads to a lot of false positives because if you're seeing them, for a fracture, well, their blood pressure is going to be high because they have pain, right? So now we're saying measure it at the annual preventative care visit. And you don't have to do it, when they come in for their ear infection or their broken arm. And so that gets us to the first of the around 30 key action statements in the document. I'm just going to walk you through what these things look like. We're not going to show you the whole thing later. So each of the key action statements has this table with it, which you can see here. At the top is the actual key action statement, and then in the bottom are all of the details about the level of evidence, the balance of risk and harm of the evidence, and even the actual papers that were used to generate that specific statement. So if you want to go back to the primary literature, where the heck did they get that? You can actually pull those papers and look at it yourself. I'm just going to show you the text from now on because this is distracting. So key action statement 1 is that blood pressure should be measured annually in children and adolescents greater than or equal to 3 years of age. However, moving on to key action statement 2, some children need their blood pressure measured every time you see them. And those are children with chronic kidney disease, heart transplants, diabetes, those higher risk children. Those are listed there in key action statement 3. All right, now the other important thing about pediatric blood pressure is it's variable, right? It's not a constant number, and we know that children have quite labile blood pressures. You can even measure the blood pressure at the beginning of the visit and compare it to the blood pressure at the end of the visit. I'm always the last person to measure the blood pressure in my clinic, and I always get the lowest number. And why is that? Because the child gets used to having their blood pressure measured and they calm down. And there's lots of etiologies for having a high blood pressure. In Seattle, it's the coffee, right? And so it's recommended to repeat high blood pressure readings at a visit, and that you still should do multiple measurements over time before actually giving a child the diagnosis of hypertension. And so that leads us to key action statement 3, which is that the diagnosis of hypertension should be made if a child or adolescent has auscultatory confirmed blood pressure readings greater than or equal to the 95th percentile, or greater than or equal to 130/80 in adolescents at 3 different visits, which is very similar to recommendations in the 4th report. Now, then what do you do at the visit when the child's blood pressure is high? So we made this little flow diagram, which I'm not that good at PowerPoint, but I can blow it up a little bit. And so basically, starting at the top, the blood pressure should be measured correctly, and there's a whole section of the guideline on how to measure blood pressure, including a link to a video, which you can have your office staff review, that was developed by the AAP, which is the only video out there that shows the correct technique in children. None of the other videos on YouTube are correct. None of the other, except for the one adult one. So anyway, starting at the top, measure the blood pressure. If it's greater than 90th percentile, then you remeasure it. If it was done by auscultation, then you can categorize it. If it was done using an automated device, you need to go back and repeat it with an auscultation. The other thing that we did was then give people recommendations for them. What do you do based upon the different blood pressure categories? So for example, if the child has normal blood pressure, then they should just have their blood pressure measured annually, and you would give them all the routine counseling about heart-healthy lifestyle like you do to every patient, right? And then compare that to if the blood pressure comes in at the stage 1 hypertension level, then they're going to bring them back to repeat it in a week or 2. If it's still high at the 2nd visit, you're going to do the leg blood pressure to screen for coarctation, and then bring them back a 3rd time, and then moving to the right, and then if that's high a 3rd time, you'll move on to ambulatory blood pressure monitoring, and then your diagnostic workup, treatment, and think about specialty referral. So, and those vary. We'll go through some of these in a little bit more detail in a minute, and actually right now. So if the blood pressure is normal or normalized after repeat, then you don't need to do anything different, as I just said. If the child comes in at the elevated blood pressure category, you should give your lifestyle recommendations and bring them back in 6 months for a repeat blood pressure by auscultation. If it's still elevated at 6 months, then you would do the upper and lower extremity, bring them back 6 months later. But then if they're still high three times over 12 months, then even those children should have ambulatory blood pressure monitoring, and then move on to diagnostic workup. But if their repeat blood pressure is normal, then you can go back to annual screening. And then stage 1 hypertension, as I mentioned, you would bring them back sooner, do the upper and lower extremity blood pressure sooner, and then if it's high after 3 visits, go on to ABPM and your diagnostic workup. If the child's at stage 2, if they're asymptomatic, then you can bring them back within a week or refer them within a week. But then if they're still high at the stage 2 level twice within a week, then you really need to get going with the rest of the workup. And we did say, people wanted us to say, well, when should we just do something immediately? So, sitting around the conference room table, we said, okay, 30 millimeters of mercury above the 95th percentile sounds like a good number to get worried about. And so those children should go to the emergency department, or if you can get them in to see Matt the same day, do that. Can I see you the same day? Yeah, I always tell people, well, the next available appointment's always in an hour, right? But my scheduling center doesn't seem to understand that. Okay, what about this issue of oscillometric versus auscultatory blood pressure? So the first point, which is very important to make, is that all of our normative data is based on auscultation. And there is no way to compare auscultation to oscillometric values. It's like comparing apples to kiwi fruit. It's so very different. But despite that, I'm sure if when I get the tour of your place later, that I'm going to see Dynamaps or whatever brand of oscillometric device in the clinics. They're easy. You put the cuff on, you press the button, and a number comes out. But that number isn't the blood pressure, because these devices don't measure blood pressure. They measure the amplitude of the oscillations of the vessel wall as the cuff is deflated, and then they use a mathematical algorithm to estimate the mean arterial pressure. And then from the mean arterial pressure, they back calculate the systolic and diastolic values. So it's all an estimate that you get from those devices. And so they're known to be wrong and to give you especially higher values than by auscultation. So we had to say in the CPG that it's okay, and Key Action Statement 5 says it's okay to use these for screening. If you're using them, go make sure it's been validated in children, because there are a lot of them that have not been validated in children. And then if it's elevated using a oscillometric device, then get out your stethoscope and auscultate the blood pressure. All right, now, ambulatory blood pressure monitoring. I've talked about this a lot already. We know that it's been used a lot. There are normative data tables available. There are guidelines for interpreting it. The fourth report, 13 years ago, we said that it could be useful, but it wasn't recommended. All right, well, so that as background, what is it, for those of you who don't know? So patient wears a blood pressure cuff that is attached to a machine. And it's about the size of like maybe 2 iPhones put next to each other. Used to say that it was the size of a Walkman, but nobody knows what those are anymore. It takes blood pressure every 20 to 30 minutes for 24 hours, records it on the little computer chip. It captures the blood pressure in all of the different settings of the individual's normal daily life. And it allows us to look at what their blood pressure is out of the office. And it's the only way to measure blood pressure during sleep, unless you're like my one patient, transplant patient's father, who puts his child to sleep wearing the blood pressure cuff. And when he knows she's in deep sleep, he measures her blood pressure, but he is the one exception. Anyway, and then what is then done is that you can So we then look at the office and the ambulatory data, put those things together to categorize the patient into one of 4 categories. Either normal, so that's normal, or what's called sustained or ambulatory hypertension, and that's high by both devices. White coat hypertension is high in the office, normal ABPM, and then masked hypertension is normal in the office and high ABPM, and that's typically seen in kids with like diabetes or chronic kidney disease. This is what a recording looks like. So kid is wearing the monitor for 24 hours. And so what you see are the red tracing are the systolic blood pressure values, and the blue is the diastolic. And you can see in this particular child, the systolic blood pressure is high all the time during the day. It does drop down during night. So this patient is a typical patient with probably primary hypertension that has elevated blood pressure during the day, but normal nocturnal blood pressure dipping. So, now we have a lot more data than we had in 2004, more data on the frequency of white coat hypertension, masked hypertension, the association of ABPM with hypertensive target organ damage, when to use it in high-risk patients like those with diabetes and kidney disease, organ transplant patients, and even data showing that it's cost-effective to use it in evaluating a child with hypertension. So given all those new data, the next key action statement in the guideline is that ABPM should be done to confirm the diagnosis of hypertension in a child who has elevated office blood pressure. And this puts the pediatric guideline in the same category as the prevailing adult hypertension guidelines. Even the U.S. Preventive Services Task Force, which is not my favorite group of people, recommended ABPM for confirmation of hypertension in adults. The British NICE guideline recommends it, and the new ACC-AHA guideline recommends it for adults as well. And so now pediatric guideline says it too. Now, there are some specific things. So there's the right way to do it. So you should do it in the right way. And again, using devices that are validated in children and interpreted using pediatric data. And then particularly we called out white coat hypertension. It is the gold standard for diagnosing white coat hypertension. And then key action statement 9 goes into a little bit more detail about diagnosing white coat hypertension. And then, as I've already mentioned, there are children with high-risk conditions who clearly need ABPM, and particularly those where they may have abnormal circadian variation, because those children may have a greater frequency of target organ damage. And it's linked to Table 12 in the guideline, which gives all the high-risk conditions and the data that have been demonstrated supporting the use in each of those conditions. And you can look at that table at your leisure. Well, what about home blood pressures? So the problem is that there aren't really good normative data for home blood pressures in children. And they're not reliable. And the problems include the fact that there's no normative data. Very few of the devices have been validated for use in children. They don't come with a wide selection of cuff sizes. And there are no good data to tell you, well, how many readings do you need over how long of a period of time to evaluate a child using home blood pressure. So we had to say that it should not be used to make the diagnosis of hypertension. But, I certainly have my patients do it, but what's useful in other situations, perhaps following the trend in blood pressure after a child's been started on medication, for example. Now, it doesn't mean you shouldn't do it because, it can be useful. And as I've mentioned, it can be used for treatment monitoring, and that's actually quite commonly used in different settings. Now, same problem pertains to school blood pressure measurements, unfortunately. There's very little evidence showing that they're reliable. There's good evidence from research studies done in the school, but that's by research personnel obtaining the blood pressure using research protocols, not the school nurse finding the sigmanometer and doing the blood pressure for the first time that month. We don't recommend using it, but maybe it can be useful as an adjunct measure later after the child's been diagnosed. And then all of those things don't pertain to school-based clinics, because in a school-based clinic, you would expect the personnel to be better trained, to be following correct technique. All right, so what about causes of hypertension? So it's important to note that primary hypertension is really the predominant cause of hypertension, at least in the United States, that we know that these children are generally older. There's a positive family history. Many of them have obesity or overweight. They have just as high blood pressure as children with secondary hypertension, but secondary hypertension is usually denoted by diastolic hypertension, whereas primary hypertension usually is systolic elevation. So the key action statement relating to diagnosis is that if you've got a child who's 6 years of age or greater, if they have a positive family history, if they're overweight or obese, or don't have anything in their history or physical exam, then you probably don't need to do as big of a workup. Secondary causes, there are many of them, of course. The most common is renal or renovascular disease. We know from retrospective case series that renal parenchymal disease or structural abnormalities account for a big chunk of high blood pressure in those children with secondary causes. Renovascular disease, the next big cause, and that they're especially likely among children less than 6. Secondary causes, coarctation. So we had a lot of cardiologists on the committee, so we have to talk about coarctation. There are specific conditions which are associated with coarctation, but the important point to make about coarctation is that even children with repaired coarcs go on to have hypertension later, and you can detect that by ABPM. In fact, that's the only way you can detect that. Once you've made a diagnosis of hypertension, patients should be evaluated to determine the underlying cause, look for comorbidities. You would do history and physical examination, and then selected laboratory and imaging studies. Key action statement 13 talks a little bit about what elements of the history you should obtain, including things like perinatal history, activity history, and then physical exam to look for findings that suggest a secondary cause. And this is very, straightforward. You're going to look for something that is a little clue that I need to dig further because this child might have secondary causes, and there's a very long table that goes into detail about that. Some laboratory testing is going to be required once you've confirmed the child has hypertension because it may give you clues to underlying causes. We did provide a table that tells you what test to do in what situation. So, in all patients, so the chair was a nephrologist, so we start with a urinalysis, right? And then some chemistry studies, lipid profile, and then renal ultrasonography in selected children. We've actually de-emphasized imaging in the new guideline. But then, depending upon if the child's obese, if they have abnormal physical findings or abnormal findings on the screening test, you would do further workup. So what about echocardiography? We know that left ventricular hypertrophy is one of the most common manifestations of hypertensive target organ damage in children. It increases cardiovascular risk independent of blood pressure. And fourth report recommended getting an echo when you diagnosed hypertension, and then if you had LVH present, start medication and obtain repeat echoes. So we got all the cardiologists together, we made some changes. We now feel that there should be less reliance on echocardiograms and that you would only get an echo if you're contemplating starting drug therapy. And the way I look at this is that we're actually want people to focus on the blood pressure number and not focus on the diagnostic test. Because we know that when you look at outcomes, it's the blood pressure number that's important. The definitions of LVH were updated, and I'm sure there's a cardiologist in the audience who's going to ask me about that, that you should get repeat echocardiograms to monitor patients who had an abnormal initial echo, but that frequent echocardiograms without knowing the patient had LVH or an abnormal echo should be discouraged. Again, focus on the blood pressure. And that gets into the treatment goals. We want the patient's blood pressure to be at a level that's going to reduce their risk of developing target organ damage and reduce the risk of later cardiovascular disease. This is it's preventative care. And this is the emphasis really of the adult guideline as well, which has been criticized for the 130/80 target. But the reason why that recommendation was made is because the evidence supports a lower blood pressure target. And even in pediatrics now, since the publication of the fourth report, there are new data that support a lower blood pressure target. And so we're recommending that blood pressure should be lowered to below the 90th percentile or below 130/80. And the same goal, whether it's non-pharmacologic measures or pharmacologic measures, is the same goal should be followed. Lifestyle interventions, however, are emphasized as the first measure to reduce blood pressure. And so children should be counseled on the DASH diet, which is the dietary approaches to stopping hypertension. And they should be counseled to have moderate to vigorous physical activity several times per week, because we know the evidence supports these recommendations because studies show that these things lower blood pressure. However, there are some children that require blood pressure lowering medications. These are typically children that have failed lifestyle change, who have symptomatic hypertension, or who have higher levels of blood pressure. The first-line agents are ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics. Beta blockers are off the list for first-line treatment. And then in patients with CKD or diabetes, you should be using an agent that targets the renin-angiotensin-aldosterone system, an ACE inhibitor or an ARB. And that's summarized in Key Action Statement 21. What about follow-up and monitoring? So you have to see these patients back. You have to, if they're on medication, adjust the medication dosing until you get them to goal blood pressure. If they're being treated with lifestyle change, you have to monitor them to make sure that they're doing it and whether it's achieving the particular goal you want, and whether you need to then change your mode of therapy. Ambulatory blood pressure monitoring is called out as being useful for treatment monitoring, and so we will do this when we're not sure from the office blood pressure or from home blood pressures whether the child has actually achieved control. Chronic kidney disease is particularly called out because of the high risk of cardiovascular complications in children with childhood onset CKD. So they need to be evaluated at every encounter. They should be treated to lower their 24-hour mean arterial pressure to below the 50th percentile, because that level of blood pressure reduction has been shown to result in decreased progression of chronic kidney disease, and that they should be assessed yearly with ABPM to screen for masked hypertension. So we're all going out and buying more monitors to be able to do that. Diabetes is also called out as a high-risk condition. Those children should be evaluated at every encounter, and that if they're at the 95th percentile or above, they should be treated with a blood pressure lowering medication. What about athletes? So people always ask about that. There's no evidence that exercising while hypertensive increases your risk of a problem. We know that physical activity is actually a treatment for hypertension, right? And in some kids, who are athletes, if they're hypertensive, you treat them, their performance gets better. I have lots of anecdotes to that effect, which you can believe or not, I guess. The recommendations are that they can participate, but they should be screened for target organ damage, perhaps a little sooner than the non-competitive athlete. And that if they are hypertensive, they should have their blood pressure lowered to below the stage 2 level before you allow them to compete. Okay, so that's very important. So you can allow them to practice with the team because that's actually going to be good for them, but we don't allow them to compete till their blood pressure is lower. Okay, so summarizing things, the major points, again, are some changes in the categorization, the revised tables, and the screening table, the use of ABPM, and the lower treatment goals, and emphasis on treating the number and not the diagnostic test. What does this mean for your practice? So, you're going to make sure that your staff knows how to do manual blood pressure measurement correctly, that you have cuff sizes available in your office. You might want to post a simplified blood pressure table. You have to figure out the right way of getting ABPM in your setting. And then I think it's important even for people in primary care to familiarize yourself with the indications for drug treatment and familiarize yourself with at least one drug from each class so you can feel comfortable prescribing. So it takes a village to be able to do all this. My village consisted of this group of people who all worked very hard, and I thank you for your attention.
Any questions? Can always count on you, Paul.
Thanks for a great talk. I had two questions. They're sort of related. One is you sort of alluded to it just at the end about figure out how to get ambulatory blood pressure monitoring. So do you think primary care physician? And my second question, white coat hypertension really going up to try?
Yeah, so the first question is, should pediatricians be ordering ABPM? Well, I think it depends on how it works wherever you're practicing. At our place, you can't order it. You have to send us the patient. But there are some people in our area who actually send these kids to the community hospital that offers it. And then they don't know what to do with the data because the community hospital is going to give you a reading based on adult standards, which are very different. So then we get the patient sent to us. But there may be, large multi-specialty groups that might want to implement it and, pick someone as the champion to do it. And I think it all depends on your practice structure. Now, with respect to white coat hypertension and whether or not it's benign, I don't think it's benign. There are data in adults that show that adults with white coat hypertension, a certain percentage of them do go on to develop established hypertension. There aren't many data on this problem in children. We're actually leading a multi-center study right now that's going to look at that. Our own internal data has indicated that many of these children change their blood pressure patterns over time. We do bring them back for repeat ABPM if they'll do it again. We ask them to come back in a year to see if they're still in the same category. But, it's not normal to have white coat hypertension. There's something different about that child, I think.
Obviously, when we're doing an evaluation for postural hypotension, we might be a heavy blood pressure lying down and then standing up. I'm assuming from what you said that the standards are all based on a seated position.
Correct.
And so, for example, if I'm monitoring my own blood pressure with one of those oscillometric, I shouldn't be lying down in bed, I should be sitting up. Is that correct?
Yeah, the standards, even in adults, is for seated blood pressures, right?
Are there any guidelines for rheumatologic patients with ABP, like ambulatory blood pressures?
Well, No, they weren't really called out. However, a lot of those patients have abnormal blood pressure because they're on a lot of steroid, or it's a child with a vasculitis or lupus that actually has renal involvement. So many of them actually do, at our place, do get sent to us for, workup and perhaps treatment.
I have a question as I'm walking down to Dr. Nelson. I work in the emergency department, and we are troubled by lots of high blood pressure readings in somewhat well children, maybe, minor illness or minor injury. How fast do we have to get these patients into their primary care providers for repeat blood pressures?
Yeah, that's a naughty question. Because there are 2 studies that have been done looking at follow-up blood pressures in children with high blood pressure identified in the emergency department, and both have shown that there's no utility or predictive value to the blood pressure obtained in the emergency department. For all those reasons you mentioned. I think what I would do is, maybe include that in your note to the primary doctor that, little Roberta had, blood pressure that was above the 95th percentile every time we, saw her for her, ear infection or whatever. And then they should probably, most of the time, if you're seeing a patient in the emergency department, you're going to recommend that they follow up with their primary care provider in a short interval anyway. So I think that could just be part of that follow-up visit.
I have a question. Yeah, we're in the midst of a EMR rollout switch, and I'm curious if you feel like there's a role for developing tools in an EMR to better identify these patients, or at least help primary care providers identify these patients.
Yes, the answer is yes. The short answer. The long answer is, how do you actually do it? And because there's lots of different approaches. I was just asked to write an editorial for a paper that's coming out in Pediatrics from a place which I can't mention, that developed this whole set of clinical decision support tools for high blood pressure. And it did increase the rate of recognition of elevated readings, but it still missed a lot of patients because it required an extra step. And I think the best approach is that you actually, when the blood pressure is entered by whoever takes it, that it's immediately categorized as normal or abnormal, and that, maybe it turns red in your EMR. And we were able to do that with the prior blood pressure values because there was a nice formula provided in the appendix to the 4th report on calculating percentiles from a specific reading. But Dr. Rosner didn't give us that in this one, and so it's becoming a much more difficult problem to solve. But I think, yes, it should be in the EMR. We actually do have a key action statement to that effect, that health systems with EMRs should develop tools to flag abnormal blood pressure readings.
Of course, they're all based on the Dynamap.
Well,
there you go.
But basically, even that, at least a way to know whether that's high, that, puts it right in your face, will perhaps then lead to the repeat value by
manual.
auscultation.
Right.
So just another question about, it seems like part of the guidelines are designed to prevent over-calling. Sit there for 5 minutes. I doubt very many offices actually have people do that. Using a sculptatory, if Dynamap is too high, come back in 6 months, then come back in another 6 months if it's elevated. So, I mean, is that a big danger of saying not
Yeah.
doing it when kids are sick? All those seem to me
So,
overdiagnosed.
yeah, there is an underlying conservatism in the pediatric hypertension guidelines. There always has been. And actually, we've been criticized for that by various people in journal articles, because there certainly are people out there who feel that you need to really be more concerned about high blood pressure readings. But, the counter argument to that is that children's blood pressure is labile. And even there's ample data that show that even children with secondary causes of hypertension have labile blood pressures and could come in one day and their blood pressure could be normal in the office, even though they have kidney disease and they have hypertension. So there is a value to repeating, blood pressures. And there's certainly nothing that says don't bring them back sooner if you're worried about them, right? We just had to figure out what's sort of reasonable. And we had several, general pediatricians on the committee who helped us figure out what is sort of reasonable in a primary care setting. And so that's how we arrived at, some of the recommendations.
Any last questions? No, well, Dr. Flynn, thank you. It's been our pleasure to have you here, and hopefully you get back to Seattle in one piece.
Yeah. Should be able to. Thank you.